Welcome to the Boomer Buzz, the show that focuses on issues of interest to the 60 and over crowd, both here on Long Island and across the country. Listen as experts keep you informed about the latest health solutions, financial options, and lifestyle choices, both for senior citizens and their families. Now, here are the hosts of the Boomer Buzz, Dr. Lamar Stanford and Patricia Stanford, corporate wellness consultant, on the voice of Nassau Community College, 90.3 WHPC.
Welcome to the Boomer Buzz, where each week we'll give you the buzz on how to stay healthy, wealthy, and wise after the age of 60.
Today we're speaking with Dr. Rachel Fermo. She's an MD and also a specialist in geriatric medicine at the Townhouse Rehabilitation and Nursing Center in Uniondale here in Long Island. We're discussing with her medical issues in the boomer population.
Welcome to the show, Dr. Fermo. It's really an honor to have you with us today.
Oh, thank you for having me.
Maybe we could start out by asking you some generic questions. What does the term geriatric actually mean? I'm thinking, could a 45-year-old person be considered geriatric, or...
That's a good question. And, a lot of people actually confuse the term gerontologist with geriatrician. So gerontologists, they focus on the study of aging and the aging population. Geriatricians are actually physicians. They go to medical school. They do residency training and a fellowship training in geriatrics and provide care for people who are 65 and older.
So it is there is kind of an age identification to a geriatric. Okay.
Yes.
Okay, excellent. In your training, what areas of medicine did they emphasize? Like we all know that old people, and I'm an old person, I just had a bypass operation. Did they emphasize cardiac, neurological, Alzheimer's, dementia, ambulatory, mental problems? Can you just kind of give us an idea of your training, what they emphasize? Because this is a fairly new specialty, isn't it?
It's been around, but there's just not as many of us, really, and we're always looking to recruit, the medical students into our field. We are actually, if you think about, your physician, you see an internist or a family practice physician, and you might go to this physician for, a cold or maybe a knee pain, whenever you feel ill. Geriatricians basically care for those same problems in people who are 65 and older. So, we deal with, heart issues, memory issues, lung issues, even social issues. We deal with a variety of things, and it's basically primary care that focuses on the elderly because the approach for the elderly is not always the same as someone who's younger than 65.
Mm-hmm. Now, how long has this, you've kind of answered that, but how long has this specialty been around?
It's been around for a long time. I know I have relatives actually, who are in the field. And it's really, just a branch of internal medicine. It's only a 1-year fellowship. A lot of physicians in the past that didn't do the fellowship, they just learned, because they were taking care of older patients, they learned to take care of older patients. But, as the fellowship gained momentum and popularity, now more people are actually having a certification and are able to, educate others and work in nursing homes and things like that with more of a background in geriatrics.
Mm-hmm. What drew you to this field of practice?
I was going to ask that. Darn.
Well, I've always had an affinity towards the elderly population. My mother is actually a nurse, and she's always worked with the elderly and would always come home with, really, nice stories, and it's always, piqued my interest. And when I was in my residency training and, at Winthrop Hospital, I, had a lot of exposure to the elderly population there, which really solidified my decision to go into geriatrics. And I've never looked back.
Okay, so you also said that you learn a different kind of approach when you're dealing with the elderly. So what's involved with that different approach?
Well, one of the biggest things is, the best examples I can give you really is like medications. So, when you're younger, your body is more resilient and can tolerate medications, and the medications affect you in a different way, as opposed to when you're older. You might not want to use certain medications in the elderly because they can get side effects or adverse reactions, or maybe the dosage shouldn't be as high, or maybe some medications really shouldn't be used at all in that population. So based on their medical conditions. And so this is something that we study and we learn in geriatrics.
Okay. So in addition to that different kind of approach, what else is the focus of somebody that comes to your facility, townhouse, for, let's say, for rehabilitation? Mm-hmm. What happens to them there? What can a person expect going
Okay, well,
in
that's
there?
a great question. So basically, the focus is really to return this person who may have gotten, ill or have had something happen, that landed them in the hospital. The goal is to get them back to their prior level of function, if not better. So, like you mentioned, I work in a rehabilitation center, a townhouse. In the hospital, we have patients who are very sick, and they might not necessarily require acute care in the hospital anymore, but they're too sick or weak to go home safely. So they, typically come to a post-acute care setting, like townhouse, and they undergo rehabilitation of sorts. So typically, the patients can expect to do physical therapy for an hour or so each day. And physical therapy is basically your muscle strengthening, your big muscles, gait training, balance training, working on stairs, getting in and out of a car, those basic things. And they also can expect to do an hour or so of occupational therapy, which is focused more on the activities of daily living, such as, feeding. Some people have strokes or they have Parkinson's and they have trouble, holding utensils and things like that. And they need training to get back to being able to feed themselves. They focus on, getting in and out of the bathtub safely, dressing and things like that in occupational therapy. Now, in a rehab setting, there's a common misconception of people who are in the hospital thinking that when they go to rehab, they'll be doing rehab all day, 8 hours a day, and that's really not the case. It's usually about 2 to 3 hours a day.
Because it's exhausting for a lot of these people. Yeah,
it is.
I've seen that.
Especially when they're critically ill. So the rest of the time is really just, recuperating. And there's a physician, here, and there's a nursing care 24/7. It's a very supportive environment.
Maybe we can just interrupt you for a moment, Dr. Fermo. You're listening to the Boomer Buzz on the Voice of NASA Community College, WHPC 90.3, and our guest is Dr. Rachel Fermo, MD. She has completed a specialty in geriatric medicine. We're discussing with her medical issues in the baby boomer population. Okay, so what is a normal day at the facility for you? What do you do as a physician at that facility? I know they do nursing care. It's a nursing home and a rehab, and I should say that my mother is a patient there, and Dr. Fermo is her doctor, and
yes.
It's one of the reasons I wanted to have Dr. Fermo on the show, because she's such a great doctor.
Oh, thank you, Pat. Well, a normal day is really, it's one of the reasons why I like it is because it's not predictable. I do have a panel of long-term patients. I do, care for your mom. And, I have my short-term patients in the rehab who tend to be sicker. So when I start my day, I usually start with the patients who are the sickest, who require the most immediate medical attention, and focus on them. And they're typically the ones on the short-term unit. And then, anyone else after that who requests to be seen on the long-term unit and the short-term unit. And what I like about working in a nursing home and rehab setting is that there's not, appointments. So, this person has 15 minutes, this person has 15 minutes, and whether or not they have a serious issue or a very simple issue, I can spend 5 minutes with my patient if that's all they need. I can spend an hour with them if that's what they need. So it's very flexible, and I really provides the geriatrician myself to provide the best care possible to my patients.
Okay, so that's excellent. So you're all around the facility seeing lots of different patients.
Now, Dr. Fermo, do you have people like PAs and nurses that assist you on that daily routine that you get into?
Oh, of course. I have excellent nurses here. There's also, as I mentioned before, the therapists. There is a physician's assistant. I know that they are common in, all aspects of healthcare. But who really sticks with me is the geriatric fellow. So this is, a person who's been through their medical school and their internal medicine residency, and they're doing that extra year in geriatrics to just glean more information and specialize their skills. They spend 3 months out of their training at Townhouse with me, just sort of following in my footsteps, and they see patients with me.
And how do you train them? I know the medical piece, I'm sure they do a good job with in medical school, but when they're actually seeing patients, how do you train them to be patient and to be good listeners? Because sometimes that can be difficult with the elderly.
Oh, absolutely. Well, first off, I think that we're lucky that the people that apply for geriatrics.
It is Wednesday, my dudes.
Typically have more patients to begin with. But it is a transition. Because a lot of times they're coming from residency where things are very hectic. They're in the hospital and things are go, and in a nursing home setting, they kind of have to take a step back and see the big picture. So that actually is something that we work on with them, and not everything is a dire emergency. That sometimes taking a step back and sometimes doing less is actually doing more for our patients. That does take some time, but the year really provides them with a lot of experience to hone in on that.
Okay, that's great. I had an experience with my parents some years ago. We went to a doctor that was recommended to us. Both of my parents were living in their home at the time, and we visited the doctor, and we had heard great things about this doctor. And when we walked in, both of them were in difficult straits. My mother could walk. My father was in a wheelchair. And the doctor said, "How are they today?" And I thought, well, they're here. They can speak to you. And he addressed all of his questions to me. And I could tell that he was uncomfortable with the elderly. And that really floored me. But not everybody has those skills. So it's definitely something that I think is I've seen at Townhouse. And it's the people are patient and good listeners. And that's wonderful.
Can I get into an area with you, Dr. Fermo? I'm 75. I just had a double bypass operation. How old? Is there a cutoff on surgery for your patients? Like somebody may be in your facility and they say, "Oh, gee, they're having some cardiac issues. Should we take them out and give them bypass operation?" Or how does that philosophical thing go? I'm sure you've run into it, haven't you?
Oh, absolutely, all the time. That decision is very individualized when someone requires, major surgery. We have a variety of patients. Here there are some people who are by number are 70 years old, but their bodies are like 90 years old. Or we might have like a 92-year-old who's sharp as a tack and, who's, physically pretty fit. Just because of genetics or what have you. So that's a very individual decision, and what I usually use to help guide the decision, to help me and the families and the patient is, kind of what their quality of life is. So if, they have a pretty good quality of life and the surgery will, shoot to sort of preserve that and, not necessarily extend their life quantity-wise, but just their quality of life, then that's something that I would be a proponent for. But, that's a very individual thing because a lot of times elderly people can't withstand surgery for a variety of reasons.
Right,
so it really comes down to quality of life, if it's going to help them or not.
Now, Dr. Fermo, you don't recognize this, but we're halfway through the show.
Oh, wow.
Hey, I'm Dr. Lamar Stanford, along with my wife, Patricia Stanford, and our guest today is Dr. Rachel Fermo, MD, who is a specialist in geriatric medicine here on Long Island at the Townhouse Rehabilitation Nursing Center. You're listening to WHPC 90.3. We'll be right back.
Adopt US Kids presents What to Expect When You're Expecting. A teenager. Learning the lingo.
Today I'm going to help parents translate teen slang. Now, when a teen says something is on fleek, it's exactly like saying, that's rad. It simply means that something is awesome or cool. Another one is totes. It's exactly like saying, totally, just shorter. As in, I totes love going to the mall with Becca. Another word you might hear is jelly. Jelly is a shorter, better way to say jealous. As in, Chloe, I am like so jelly of your unicorn phone case.
You don't have to speak teen to be a perfect parent. Thousands of teens in foster care will think you're, rad, just the same. To learn more, visit adoptuskids.org. A public service announcement brought to you by the U.S. Department of Health and Human Services, Adopt U.S. Kids, and the Ad Council.
Welcome back to the Boomer Buzz on the voice of Nassau Community College, 90.3 WHPC. Our guest today is Dr. Rachel Fermo, MD, who is a specialist in geriatric medicine. We're discussing with her medical issues in the boomer population.
Now, Dr. Fermo, a lot of our listeners, or a number of our listeners, I should say, are looking after aging parents. Now, what are some of the major concerns for looking after homebound seniors? I know that's part of your training. You're in a facility, but I'm sure you've dealt with home care for seniors. And can you just maybe mention some of those concerns that you've seen as you visited homebound seniors with certain issues?
Sure. Well, it's nice to see people living at home. That's obviously, if they're able to, we want our patients to be able to live at home. But there are some, things that, you can sort of pick up on as a child of an elderly parent that should, sort of maybe make you think that they might need some help in order to allow them to continue to flourish at home. So, like I mentioned earlier, there's something called activities of daily living, and these are things like transferring in and out of a chair or the bed. It's dressing, it's bathing, it's grooming and feeding. If you're starting to see, your parent have issues in those skill sets, it might be time to either provide the help yourself or, maybe consider hiring someone to help, even if it's for a couple of hours a day. I think a lot of people have a misconception that, home care is covered by insurance, which it's not. It's actually private pay, and it can actually, be pretty pricey. But it's something that, you have to sort of, think about to keep your parents safe at home, and allow them to thrive in that setting.
I remember moving into Pat's parents' house after they had been put into an assisted living. And in the bathroom, there were a couple of grab bars, and I said to Pat, what's going on here? Little did I know that a few years later, I would be grabbing those bars. And so it's kind of interesting how you kind of generate into, or degenerate, I guess you could say, into using some of these facilities around the home. But now, another question. Why do seniors, and I've fallen into this also, why do we forget to take our medicines on a daily basis? It just, I guess, balance and memory are two of the things that start deteriorating as we get older, right?
Yes, I mean, you can have definitely memory. It gets a little challenging when you get older. But, you should still, there are certain things that you should still remember to do. Like you should still remember who your family members are. You should still remember your address. You should still know the date and where you are. But, little things like that, it's expected. Just little blips here and there. It's troubling if you can't remember, what you ate for breakfast that day or seeing the doctor the day before. That's when memory impairment might be a little more serious. But all ages go through that.
Right. What about balance? I hear these statistics about how many people, seniors, die every year through falls.
Right.
That's got to be a major concern, right?
Well, balance is very important, and like you said, falls. So many people do fall, and in the outpatient setting, it's always good to, if you're able to, is to participate in exercise classes if you can, and if you need a little bit more help, there's a lot of physical therapy. Gyms around all over Long Island, and you just need to talk to your physician and let them know that you feel like you have balance issues, or you're fearful of falling, or you feel weak or not as strong as you used to. You're not able to do things that you used to do, and a lot of times your physician will provide a prescription for you to go to a physical therapy gym and get more specialized training, and it is very helpful, and it does help to prevent falls, especially with the balance.
Are there other things that you can think of that you would advise people to do to maintain their independence? Because that seems to be something that you can do to maintain your independence, is to be in better physical condition. Yeah,
absolutely. I think keeping up with your doctor's visits, anything that annual hearing tests and the vision tests, a lot of these things that you don't realize are going, like if your vision is poor and you start having difficulty driving, and then you get your license taken away, then you're stuck. So keeping up with simple things like that can really help to keep you as independent as possible. And also a big thing is learning when to accept help. So as you get older, your body there's a normal wear and tear, which is expected and perfectly acceptable. It's just knowing that when you do need help and accepting that help, and that can be challenging, especially people who've been very independent most of their lives. But the thought is, in order to keep you independent, accept a little help so you can stay in your home.
Mm-hmm. That makes great sense. And I want to say that you're listening to the Boomer Buzz right now on the voice of Nassau Community College, 90.3 WHPC. Our guest today, you're listening to Dr. Rachel Fermo, MD, who's a specialist in geriatric medicine here on Long Island, and we're discussing medical issues in the boomer population.
Now, Dr. Fermo, we don't want to put you on the spot, but what is it in your training that makes you a better physician than a regular GP or general practitioner for the elderly?
Well, I think that it's really just we're trained to take care of patients in all different kinds of settings. So we take care of patients in the outpatient setting, in the hospital, but we also have a lot of experience in the nursing home setting, the rehab setting, assisted living facility settings, where a lot of GPs or internists don't really venture out to. Traditionally, they have, their office practice, or they go to the hospital, but these other sort of facilities are typically staffed by, geriatricians, and we just have that extra experience for caring for patients in those settings.
Now, do other countries have this specialty, like in Europe and in Asia, or is this kind of are you a pioneer, in other words?
I don't think we're a pioneer. I don't know if they have, fellowship training, or if if geriatrics is incorporated into their regular medical training. I'll be honest with you, I don't know much about what goes on in other parts of the world, but there are elderly people everywhere, so I'm sure they have some knowledge and some subset training in geriatrics.
Right, you hear about that in Asia and Japan in particular. They have a very serious aging problem, and I suspect they've maybe instituted something over there. Now, one thing, we hear a lot about dementia and Alzheimer's in the aging population in our country. Do you have any secret cures you can give the audience to avoid this sad situation?
I wish. I mean, that's our greatest wish, is to, be able to obliterate this disease. But, there's really no cure right now. There are medications out there that are geared to not reverse memory loss and cognitive impairment, but slow it down. They are not always effective, but, it's certainly good to try if the doctor recommends it. But just simple things like just keeping up with the current news, doing word games and things that really sort of test and push your cerebral function is always good. You always want to keep your mind busy.
Mm-hmm.
So just looking at things in general, the future of your specialty and the aging population, what do you see happening in the next 5 to 10 years? Do you think that there will be cures for some of these diseases, or are you hopeful about where things are going, or are you concerned?
Well, I mean, I'm a little concerned just because the aging population is really projected to rise, significantly in the next, 20, 30 years or so, because of the baby boomers. They're all, I think since 2011, they've all been turning 65, and every year, they said something like 10,000 Americans are having their 65th birthday every year. And so the population is growing, but the amount of geriatricians in the world is not.
Right.
It's still primary care. It's not a specialty. So we're always actively trying to recruit people into our field because there's only so many of us, and we want to be able to provide that comprehensive care to the population that's ever growing. So it is a little concerning, but we do our best to recruit people into our field.
Now,
okay.
we're
gonna get our grandchildren to go into that, right? That's what we're gonna have to do.
Hey, Dr. Fermo, before we're just about getting to the end of the program here, but 4 states have made it legal for a physician to help a terminally ill patient end his or her life. Is this a coming practice overall, and is there an area of in your training? Is that area addressed?
Well, death is a very common thing that we see, as geriatricians, as people. We take care of people at the end of their life, their last leg of life.
Mm-hmm.
And, in my training, palliative care is a focus because there does come a point where, sort of the regular medical interventions that you would do for someone, doesn't really help them anymore. It doesn't, like I said, doesn't improve their quality of life. And so, a lot of times we can, we take a step back and say maybe instead of doing everything by the checklist here, we should just, focus and shift the approach onto a palliative approach, which is more, on comfort, dignity, and peace at the end of someone's life who may have a terminal illness. And that is, I think, a very important part of what I do. And I help, families, go through that and educate them on what that means. Palliative care doesn't mean that you're giving up on somebody. It's just, shifting the focus to a more comfort and quality approach at the end of someone's life.
Excellent.
Now, do you consider your facility there kind of a hospice? It sounds like you've got palliative and hospice kind of there together, doesn't it?
Well, not necessarily. We do have palliative care, and the physicians are the ones that provide the palliative care. There are hospice agencies, and folks are definitely able to have hospice, but it's not really such a focus here in the nursing home because we're able to do the palliative care. As the physicians, we're able to do all the palliative care. Hospice is really good for those folks that are still at home or are able to be at home and want to be at home, but get the palliative care services there.
This has been great. We want to thank you, Dr. Fermo. This has been a great conversation, and we want to thank our guest, who is a geriatric medicine specialist at the Townhouse Rehabilitation and Nursing Center in Uniondale, Dr. Rachel Fermo. This discussion has been interesting and informative, and we hope to get you back sometime, Dr. Fermo.
Thank you. I'd be happy to. I'm
Patricia Stanford, along with my husband, Dr. Lamar Stanford, and you've been listening to the Boomer Buzz on 90.3 WHPC. This show will be available as a podcast on iTunes, Android Podcasts, Spotify, and Spreaker.com. If you have any comments, email them to us anytime at WHPC@ncc.edu. Thank you for listening to the Boomer Buzz, here on the voice of Nassau Community College, 90.3 WHPC.